Good morning. Neha, thank you very much. That was very generous. Slide, move forward. Great. I'm deeply honored to be here. This is a very special occasion, and I truly am humbled by being here. We are here, obviously, to recognize a man who was extraordinary. Dr. Satya Paul was somebody that I'm sorry I did not get to meet, because I would have liked to meet him in person. This gathering is about him, but more importantly, it is about his legacy. And his legacy really is the family that he created. And I will have to congratulate all of you, because as somebody who's a father of a family, I will tell you that it is extraordinary, the legacy that he created. Kusma, by you and your children, have been extraordinary. Because it is not every day that we have great industrialists, great entrepreneurs, great economists, great business people who also recognize that wealth, assets, growth is much more than about themselves. It is about making the world a better place, because that's truly our legacy. And so for that, we thank you and we congratulate you. Let me start out in my lecture. My lecture is entitled Metabolic Syndrome in Women, Unraveling the Complexities and Implementing Effective Strategies, and I will only be able to touch on this, because there is no way that I can unravel the complexities of what I'm going to talk about. As we said, this is in recognition of Dr. Satya Paul, which obviously I don't need to mention any further, other than, again, to say I wish I had actually met him. I have a few conflicts of interest. I can guarantee you that none of those pay me enough for me to say something different, so what I say is my own opinion. I do wish somebody would pay me enough for me to change my mind, but apparently that's not enough. So, what we'll do today is we'll cover in the next 45 minutes or so some general concepts about metabolic syndrome and metabolic dysfunction, as well as PCOS. Some mechanisms of, we'll talk a little bit about the mechanisms of metabolic dysfunction and PCOS. We'll talk about the treatment of metabolic syndrome and metabolic dysfunction, and then have some concluding remarks. Now, metabolic dysfunction affects a broad swath of the population of most countries. Metabolic dysfunction leads to certain disorders, right? It leads to cardiovascular disease, metabolic dysfunction-associated stereotactic liver disease, or what now is called MASLD as opposed to NAFLD. Sleep apnea, cholelithiasis, a large number of problems. So metabolic dysfunction is something that we obviously understand. And clinically, it presents differently. It presents as diabetes, as metabolic syndrome, as polycystic ovary syndrome, as lipodystrophy, and a large number of other disorders. So there are a number of definitions of metabolic syndrome, and I'm not going to bore you with this, except to say simply that they all are somewhat different. Some of them require you to have insulin resistance first, and then other features. Others require you to not have anything at all and simply have a few of the features. We generally, tend to use the NA-NCAP ATP diagnosis. That's the one we tend to use most, at least in the United States. Now, in most countries, about 20 to 30% of adult women have metabolic syndrome. 10 to 15% of reproductive women have polycystic ovary syndrome, and about 7% of the population has diabetes. And the prevalence of metabolic dysfunction is on the rise, driven in part by changes in nutrition, exercise, and the global obesity pandemic. Now, in India, and this is a meta-analysis that was recently published, you can see that the prevalence of metabolic syndrome is also very high in this study. It rises from about 13% of the population among women who are, among individuals who are 18 to 29, to as far high as 41% of the population for individuals over the age of 60. That means that truly more than half of the population of India will eventually be affected by metabolic syndrome as they age, which is dramatic. The, again, proportion of metabolic syndrome is higher in women. And this is something that we often underestimate. About a third of all women will have metabolic syndrome. About a fifth of all men will also have metabolic syndrome. And finally, there are differences in region, right? It is about a third of individuals in urban areas and tribal areas will be affected, but it is less, significantly less, in rural areas of India, which tells us that actually some of the environmental factors, our nutritional factors, our behaviors will actually impact that prevalence. So India is not immune to the epidemic of metabolic syndrome that we have in the world. Now, how does metabolic dysfunction occur? Well, the principal really mechanism, and we'll talk a little bit about this as we talk about some of our research, but the principal really is an impairment in insulin-mediated glucose uptake. In other words, in the action of insulin on glucose. That is the principal mechanism by which you have metabolic dysfunction, along with a dysfunction in lipolysis inhibition. You may all remember that insulin has three principal effects. It actually helps move glucose into the cells, right? Insulin-mediated glucose uptake. It inhibits lipolysis, right? And it has anabolic effects. It stimulates certain tissues to grow. But in general, insulin resistance does not actually impact the anabolic activities of insulin, which are actually managed by MAP kinase. It's a pathway we'll talk about. It primarily impacts the insulin and the lipid section of insulin. And this is why insulin resistance tends to be dangerous, because it doesn't affect tissues and it doesn't affect mechanisms equally. Now, it is important to understand that there are a lot of other factors that modulate this. It isn't just these two things. Genetics will do this. There's a large number of differences and the large number of environmental factors that impact on how metabolic dysfunction is presented. So some of the metabolic disorders, like polycystic ovary syndrome, are also involved hyperinsulinemia. So it isn't enough to have insulin resistance, but if you have excess insulin, you then have the effects of excess insulin, which we're going to talk about in a second. So let's take a pause now for a minute. We've talked very rapidly about what metabolic dysfunction is. And we know that the principal, one of the most common clinical disorders associated with metabolic dysfunction in women is polycystic ovary syndrome. Now, polycystic ovary syndrome can be confusing to people who don't actually know it. But to be fair, I would say it is very simple. Now, there are three different criteria that have been used: NIH 1990, Rotterdam 2003, and APCOS 2006. And I've been very fortunate to be involved in all three of these. But I will simply say that that's not what we care about today. What we care about today, and you as practicing clinicians should know, we tend to divide PCOS into phenotypes. And so there are generally three principal types of PCOS that we talk about. We talk about classic PCOS, the A and B phenotype, right? These are women who have excess male hormones, hirsutism, hyperandrogenism, polycystic ovaries, perhaps, and ovulatory dysfunction. This is what we call classic PCOS. Then there is phenotype C, which is what we call ovulatory PCOS. This is PCOS that actually really has excess male hormones, polycystic ovaries, but actually normal ovulation. And finally, phenotype D, which is the most complicated of the phenotypes. It's the most controversial, I should say, not complicated. And that is individuals who have non-hyperandrogenic PCOS. They have polycystic ovaries, ovulatory dysfunction, but again, don't have androgen excess. And again, if you look at this chart, you will see that today we should be speaking about the different types, phenotypes of PCOS, not just which criteria you use. It makes absolutely no difference which criteria you use. It makes a difference, as I'll show you, why the phenotypes matter. Now, PCOS is a diagnosis of exclusion. It is a diagnosis that only remains after you have excluded things like thyroid disorders, Cushing disorders, tumors, and everything else, mostly by history. So it's important to remember that every patient with PCOS should be screened for similar disorders, and that is TSH, prolactin, and 17-hydroxyprogesterone. If you don't do that, you actually don't have PCOS. So I think it's important to remember. All right. Now, the pathophysiology of PCOS is, sometimes complicated, but the truth is, it's not very complicated at all. You have insulin resistance stemming mostly from adipose tissue dysfunction. I'll show you some data on that. There is gonadotropic abnormalities with excess LH, if you would, an insensitivity to progesterone. And then that impacts on the ovary. The ovary produces too much male hormones. The excess male hormones then impact ovulation and impact other features like the liver. So it is not a complicated disorder. What is complicated is, why does it start in the first place? And that we don't yet know. Now, the prevalence of PCOS is actually high. I will tell you that my team did the first study of the PCOS prevalence. In 1998, we published a study which was actually the first prevalence study in the world. Until then, we actually thought that PCOS was relatively rare. We thought that maybe we see PCOS because we're specialists or something like that. But in 1998, we did a study that we surveyed and we studied women who were coming in for a pre-employment physical and found that, in fact, 5 to 6 to 7% of those women were actually affected with PCOS, which was shocking to us, and it was shocking to the world at that moment in time. And since then, many other studies have replicated that finding, and so today we know that PCOS is the single most common endocrine disorder of women worldwide. We ourselves have done a large number of these studies. We have studies in Nigeria, Ghana, Colombia, Siberia, Trinidad and Tobago. We've done studies all over the United States and in Europe and the Middle East, trying to prove that perhaps PCOS is not as common in other countries. And what we find is that, in fact, it is as common in all countries as possible. This is a meta-analysis of that showing that it, in fact, affects a large number of individuals. Now, metabolic syndrome is also very common in PCOS. In most studies, and this is another meta-analysis, and I will tell you that while my students love to do meta-analyses, I don't like meta-analyses very much. And the reason is, meta-analyses often simply magnify the same errors all the time, right? So if all the studies have a single error, they just magnify them. But they are good to illustrate. They have nice graphs, so we can use them. But the reality is that metabolic syndrome is very frequent in PCOS, and it's most frequent, of course, in PCOS of women who are obese. Now, all of this leads to an increase in various complications. It increases the risk of endometrial cancer. It increases the risk of impaired glucose tolerance, diabetes, gestational diabetes. It increases the risk of metabolic syndrome, dyslipidemia, strokes particularly, and possibly cardiovascular deaths. We don't really know much about cardiovascular deaths because it's actually difficult to test that in younger women. But the risk of stroke is much higher in women who have PCOS than otherwise. And all of this really translate into a very heavy economic burden. This is a study we published this year or a few months ago in which we calculated the healthcare-related economic burden of PCOS in the United States, and this is just the United States, and the cost of healthcare-related economic burden of PCOS was about $15 billion yearly. Now, this is in the United States alone, and this is not in considering things like indirect costs related to work productivity, not related to, intangible costs which are related to quality of life. So the economic impact of PCOS is enormous in a society, and I think all of us who treat it understand that. Now, sometimes we tend to forget who actually did these things for the first time. So this is a study by Bergen, Gibbons, and Katabchi, and they were at the University of Tennessee. And this is a story that will tell you how sometimes mistakes can lead to actual good findings. Because Bergen was a young pediatric endocrinology fellow who needed a research study. So Gibbons was OBGYN chairman, and Katabchi, who was actually heading the fellowship program, said to Bergen, why don't we study the impact of male hormones, right, androgens, on insulin resistance? We can't actually give women androgens, although I don't know why they didn't want to do that. But let's go to the OBGYN chairman who studies these things called polycystic ovarian disease, and all these women have high male hormones, and so hence we'll test what happens with high male hormones in women. And so they did a very simple study. They just got a few women with back then, polycystic ovarian disease, PCOD, and a few women that were normal, and they did oral glucose tolerance tests, and lo and behold, they found that the women with PCOD were very high, had very high insulin levels in response to the glucose tolerance test. And so the first postulate was, okay, androgens do this. Except that actually they realized shortly thereafter that it had nothing to do with androgens, that these women were affected with insulin resistance independent of their androgens. Because even when they were treated with birth control pills, they still were insulin resistant. So this is how we got to know that patients with PCOS actually were insulin resistant. The study was published in 1980. And again, it was a mistaken study. It was a study based on a mistaken profile, but the authors understood that. This has been confirmed by many other authors. This is data from Andrea Dunave, who again collected insulin-mediated glucose disposal using a clamp. So we know that PCOS women do have insulin resistance. It's clear. And the prevalence of that is somewhere between 75 and 85% of all women with PCOS. So what does that matter? Why does that matter? Well, it matters because of this. This is a data from John Nestler, a good friend of ours. And John studied the effect of insulin on the ovary. And so what he found is the following. When he put insulin in with cells from patients with PCOS, with ovarian theca cells from patients with PCOS, that insulin stimulated a massive discharge of androgens. When he did the same thing with normal cells, with cells from normal in women, the response for androgens was very small. So what we know is that PCOS women tend to have a hyper response to androgens. And he went on to test that even further. What he did is he gave women diazoxide, which suppresses your insulin. You can't do it for too long because people die. But he did it for about 10 days, and he found that as he suppressed insulin, the androgen levels dropped as well. So what we know is that PCOD, or PCOS as we call it today, isn't just related to insulin resistance, isn't just related to hyperinsulinemia. It is related also to hyperresponsiveness of the ovary to that insulin. So this is a cartoon of what we know today about PCOS. So we have a number of factors. Insulin receptor abnormalities, adipose tissue dysfunction, I'll show you a little bit of that. And that all leads to insulin resistance, to difficulty in insulin managing glucose and lipid levels. What happens in women with PCOS is that they have pretty good pancreatic function and they have a lot of insulin. Hyperinsulinemia is produced, very high levels of insulin. And that high level of insulin then stimulates the ovarian theca together with LH to produce then hyperandrogenism. And that hyperinsulinemia also suppresses the liver to then again suppress SHBG and help hyperandrogenemia. So in general, it isn't so much the insulin resistance in PCOS, it is the hyperinsulinemia that actually matters. And that's the one that we need to be paying attention to. So my group has studied primarily adipose tissue dysfunction to understand the cause of insulin resistance, and I'll show you a little bit of this data. So this is studies that we've done over the years. You can see here that if we look at insulin resistance in adipose tissue cells, fat cells, you can see that PCOS patients have significantly lower levels of glucose uptake for insulin compared to controls in the red. And if you look here at GLUT4 being the principal action item, the principal actor to create glucose transport, you will see that PCOS women have much lower levels of GLUT4 in adipose tissue than normal. We looked at a number of things, a number of pathways. I'm not going to go through these pathways, but just to show you that we did a large number of studies in adipose tissue cells trying to figure out if there was an abnormality in the cell signaling pathway. And we found some, but not a lot. And in the end, what you need to know is that cell signaling appears to be relatively normal, at least initially, in these patients. Secondly, what we found is that there are epigenetic changes in PCOS. So that epigenetics plays a huge role in why PCOS occurs. This is a study that we did. We've done a number of studies looking at microRNA 93. It's an epigenetic factor. And what we find is that microRNA 93 is overexpressed in PCOS, and it's related to both a decrease in glucose transport and an increase in HOMA in patients with PCOS. So again, this is evidence of epigenetic control of insulin resistance. Again, epigenetics that can be managed therapeutically if we had an interest in doing so. We also studied adipose cytokines. As you know, adipose tissue produces a number of hormones that control itself. And macrophages that are also in adipose tissue produce these products that control the adipose tissue. So it's this system in fat that controls itself. But what we found is that, in fact, when you actually try to determine how fat function in PCOS versus controls, in PCOS it was very different. In fact, IL-6, MCP1, and TNF-alpha, these are adipocytokines, had very different effects on adiponectin, which is a good, if you would, a product in fat. In PCOS, those products suppress adiponectin, made inflammation worse. In controls, it didn't have much of an effect. So again, there's a large number of abnormalities in adipose tissue to do that. And what we know is that insulin resistance actually can be predicted clinically. So you don't need to do a lot of tests to actually predict that your patients have insulin resistance. Certainly if they're obese, that helps. But also the severity of menstrual dysfunction. This is a study that we did a few years ago looking at how severe menstrual dysfunction was. And the more severe menstrual dysfunction, the more likely the patient was to be insulin resistant. So again, patients who have amenorrhea will be more likely to be insulin resistant and hyperinsulinemic than patients who have relatively regular frequent cycles. There's a significant relationship between male hormones, androgens, and the degree of insulin resistance. This is a study, again, by Govinder, looking at this, and you can see that free androgen index was a very strong predictor of metabolic syndrome and insulin resistance. In a very recent study published last month in Cardia is a large prospective study of the population. We've been involved with Cardia. what we find in cardia is that androgens, male hormones, androgen levels, are predictive of the risk of women developing metabolic syndrome in the future. So in this particular result, 30% of women developed metabolic syndrome when they did not have metabolic syndrome to begin with. And what we found is, after adjusting for a number of things, the excess male hormones in these women was related to their metabolic syndrome. In other words, higher androgen levels were predictive of your risk of metabolic syndrome 23 years later. So again, androgens matter. And for example, hair growth. A lot of patients have hirsutism, and we tend to think that hirsutism is related to male hormones, but the reality is the strongest predictor of excess hair growth, of too much hair growth, is actually insulin and insulin resistance, HOMA-IR. So in fact, excess hair growth on the face is related to androgens, but the degree, the severity of that hirsutism is related to insulin resistance and hyperinsulinemia, which means the more severely hirsute the patient is, the more likely she is to have insulin resistance. And again, the phenotype. Remember, we started a lecture today by talking about the phenotype A, B, C, and D. The phenotype plays a significant role. Phenotype A and B and perhaps C are highly related to the development of metabolic syndrome. Phenotype D, which is a non-hyperandrogenic PCOS, is not. Which is why it's so critical that when you diagnose your patients with PCOS, you actually define them as phenotype A, B, C, or D. Now, I'm going to shift gears a little bit and talk a little bit about the metabolic evaluation of patients with PCOS. You can obtain a fasting glucose, you can obtain a fasting insulin, you can even do a hemoglobin A1C, but these are not very good predictors. What you need to do, and all societies have already recommended this, is that all patients with PCOS must undergo a 2-hour glucose tolerance test. And the reason is that you cannot predict glucose intolerance if you don't actually do a glucose tolerance test. So the data is here. This is very simple data. This is a study from Rick Legro, again, a good friend of ours. And what he did is he studied about 254 women by oral glucose tolerance test. These are women with PCOS. And what we find is the following. The baseline level here, okay, down here, cannot predict the 2-hour. Because in fact, if you use a cutoff of, say, 126 to predict diabetes, you're going to miss half your patients with diabetes. Because PCOS women are different than your standard diabetics. They have very good pancreatic function. They have hyperinsulinemia. And only when you stress them with a glucose tolerance test will you actually then find out that they have insulin resistance and hyperinsulinemia. So again, it's very important to do a glucose tolerance test to determine whether these women have impaired glucose tolerance or diabetes. And we also measure insulin during the glucose tolerance test. And the reason we measure insulin is that, in fact, we want to know if they have hyperinsulinemia. Remember what I said. PCOS is related to insulin resistance, but the reason women develop PCOS is the hyperinsulinemia. That's really what matters, because it is the hyperinsulinemia that is driving the androgen production by the ovaries. So we obtain and we measure insulin during the glucose tolerance test to help guide our therapy. We don't give metformin to everybody. We give metformin to people who actually need it. And again, it's about 2/3 of the women we see, but not everybody. So when we shift gears into looking at metabolic syndrome, there are two principal reasons or goals, if you would, to treat metabolic syndrome. One is to treat whatever the underlying cause is. For example, having people lose weight if obesity is driving this. And the other is to treat cardiovascular risk factors if they're present. So those are the two goals, if you would, of treating metabolic syndrome. And this is a study, it's very complicated, I'm not going to go through it, except to say that these authors, and this is just published a couple of months ago, these investigators did an interesting study.
They put women on a weight loss diet for eight weeks. They lost weight, and then they randomized them into 4 different treatments. They either placed them on placebo, they either placed them on exercise alone, they either put them on liraglutide, as you know, a GLP-1 agonist, or they combined exercise and liraglutide. And what they found is that the most effective means of maintaining and continuing to lose weight and continuing to improve insulin resistance in these women was the combination of exercise and liraglutide. So GLP-1s are having a role in PCOS. This is a study that we did some time back. And what this study looked at was to determine the type of diet that women with PCOS would benefit from the most. And what we found actually is that a hypoglycemic diet, even if it was eucaloric, even if it was not hypocaloric, meaning even if they were not destined to lose weight, was the best diet to improve their insulin resistance and even lose weight, despite the fact that they were actually still taking the same amount of calories. So a hypoglycemic diet did the best in our patients with PCOS, and we tend to recommend that as part of their lifestyle modification. And then when you look at metformin, we always talk about metformin, and it is not vitamin M. You know, we can't just give everybody metformin, please don't do that. But the reality is that it does appear to improve insulin resistance, of course, and the long-term risk of glucose impairment. But no study has looked at the impact of metformin on diabetes. So it's important to actually understand that we don't yet know, does metformin reduce the risk of diabetes in patients with PCOS? We think it does. We assume it does, but we don't really know. We did this study a long time ago. This is the first study of thiazolidinediones in PCOS. This is a study with troglitazone. And troglitazone was a thiazolidinedione, a TZD, that was extraordinarily effective in reducing insulin resistance in women and in women with PCOS. This is the study you can see. It's a placebo-controlled dose-ranging study. Unfortunately, troglitazone was withdrawn from the market. It had some liver impacts, some cardiac impacts, rarely, but it still had issues, and so it was drawn from the market. But today, we actually need to keep in mind that thiazolidinediones are very effective in women with PCOS. We'll talk about it in a second. This is a recent study also looking at various different medications in PCOS. And what I think is important to understand is that exenatide, again, a GLP-1 inhibitor, actually is very helpful a GLP-1 agonist is very helpful in the treatment of PCOS and in reducing weight in these patients. Finally, this is a study that came out very recently. And the interesting thing about the study is that they used a network type of analysis to determine, just with the current literature, what was perhaps best for PCOS in treating their endocrine metabolic status. And what we find is that, in fact, thiazolidinediones are probably one of the most effective drugs to use in patients with PCOS. So again, when we treat patients with PCOS, metformin is helpful, but metformin in combination with thiazolidinediones will be much more effective. All right, so one last piece of advice. As you look at patients with PCOS, remember that in your clinic, you are seeing one part of the elephant. You all know the story of the wise men, actually in India, a group of wise men in India who are blind men in India, were touching an elephant. And some of them said that the elephant really was like a snake. And some of them said that the elephant was like a tree trunk. Some of them said that the elephant was like the wall, because each one was touching a different part of the elephant. And that's what happens to us in OBGYN when we look at polycystic ovary syndrome. If you do infertility, all your patients have infertility. But you know what? A third of patients with polycystic ovary syndrome do not have infertility. If you do obesity, and if you see patients, most patients with PCOS will be obese. But the truth is that 60% of patients with PCOS are not obese, even in the United States. If you look at patients like I do, that I study hirsutism, most of the patients with PCOS will be hirsute. But in fact, only about 2/3 of patients with PCOS are hirsute. So you have to remember that what you see in your clinic is biased. And we did this study here a number of years ago looking at the impact of referral bias on PCOS. And what you find is the following. When we compared PCOS in our clinic to PCOS that we found in the population, what we found is that they were more frequently white. Remember, in the United States, there are significant differences in access to health care based on race. They were more obese, much more obese than population at large. They were more hyperandrogenemic than the population at large. So you have to remember that the reason we miss lots of patients with PCOS and we miss their diagnosis is we have assumptions. We assume that they're obese, we assume that they're hirsute, we assume that they're infertile, and in fact, they may not be any of those things at all. So, in conclusion, in most countries, 20 to 30% of the adult population has metabolic syndrome. In women, metabolic dysfunction presents most rarely as PCOS. And PCOS affects some 10 to 15% of women and is a lifelong disorder, although it's most clinically evident during the reproductive years. In PCOS, metabolic dysfunction results in impaired insulin action, most notably at the muscle and adipose tissue level. I showed you a little bit of that. And it results in hyperinsulinemia, which drives the androgen excess of the disorder. The treatment for metabolic dysfunction includes lifestyle modification, different diets, exercise, and so on, a low glycemic diet, but it also includes the use of other things, bariatric surgery, metformin, thiazolidinediones, GLP-1 agonists, and much more. The key to the treatment of patients with polycystic ovary syndrome is that you need to individualize the treatment of each of those women. It is not just a common treatment for everybody. Not everybody needs metformin, not everybody needs GLP-1 inhibitors, not everybody needs a diet. It's a combination therapy. You don't just treat them with one thing or another, right? You don't just treat them with birth control pills, you don't just treat them with anti-androgens, you use a combination of medications. So it's important to do that. So I've tried to cover a lot of ground in 45 minutes. Thank you for your attention, and I appreciate your being here.